program but they want to make sure they're ready.
And then you'll be able to put it on. Yeah.
All right, we'll go ahead and get started right at 1 o'clock, or yeah, 1 o'clock now. So welcome to our educational session. We'll do some brief introductions in the room, and then for those on the phone, if you would please enter your name and the facility that you work at into the chat box, into the public area, so we can make sure to note that you attended. And then we'll get started with our educational session. So I am Jessie Bond with St. Luke's, the chapter president.
I'm Brad Wickless with Northwest Medical Partners.
Tara Jones, Infection Prevention Meridian.
Kathy Pierce, St. Luke's, Infection Prevention.
Nathan Prescott, Infection Prevention.
Anita Partridge, Infection Prevention for First Choice Home Health.
Holly Williamson, Infection Prevention for Avamere Transitional Care and Rehab.
Trent McAllister, St. Luke's, Infection Prevention.
Debbie Cutforth, Infection Prevention at Howard County Hospital.
Chris Carter, Career Epidemiology Field Officer, assigned to the Division of Public Health.
Terry Noyes, Infection Prevention here at St. Allen's, Boise.
And then we'll go ahead and get started with our educational session on pandemic influenza. And Debbie, do you want to introduce
Do you want to just
Dr.
see your
Carter?
own, or do you want me just to read this? Okay, I'll just read her little bio that she sent, and
Sure.
we'd like to thank her for taking the time to come over and talk to us about this. Dr. Chris Carter is the Centers of Disease Control and Prevention Career Epidemiology Field Officer, assigned to the Idaho Division of Public Health, where she supported epidemiology, preparedness, and immunization programs for 17 years. During the 2009 H1N1 influenza pandemic, she directed medical countermeasure response to the Division of Public Health. She's currently coordinating with the division staff to update the division's pandemic influenza response plans and preparations. And we just think going right into the flu season, this is a really good reminder, and it would be something we can all take back to our facilities and maybe use in our everyday careers. So I'd like to thank Chris Carter for stopping by and giving us this presentation today.
Thank you. Well, I'm really excited to be here because I'd be totally terrified to go to hospital and for anything unless you guys weren't there. And I think because we just had the 100-year anniversary of the 1918-1919 pandemic, there's been a lot of more attention to that. Recently, and I think we just had a national exercise that some of you participated in. I think it's a good timing to talk about pandemic influenza while people have some heightened interest. So I had three main objectives today to talk about that came from questions that people sent to me for things that they would like to see covered. There were a lot of them, so this is a bit of a potpourri, and it won't cover everything that everybody asked for because I don't have 3 hours. So I kind of chunked it down to these three things. They described the evolution of pandemic influenza, considerations for healthcare planning for pandemic influenza, and then I really wanted to show you where to find tools and resources for pandemic influenza planning.
Yeah, so it's down this corner. This is the newer version.
You should be able to use that.
Yeah, that should work too.
Next. Perfect. Okay, so sometimes, I'm sure you don't, but sometimes people get confused about what's an epidemic and what's a pandemic. And I will say the slides are text heavy, So there'll be some redundancy between the slides and what I'm saying, and that's because I was told that you post the slides as a resource for everybody, so I wanted to make sure everything was on there and easy to find. So the epidemic is really when you have cases of illness or some other kind of thing that you're condition, health-related behavior event that are above what you would normally expect. And a pandemic is when that's occurring worldwide or across international boundaries and usually affecting a large number of people. So this is, when I talk about greater than expected, that's one reason why we do surveillance and we count cases, is so that we'll know when something is greater than expected or not. And this is an example from Canada from 1950 through 1972, where the red line shows their expected deaths from pneumonia and influenza every year, and then the black line shows what they actually saw and the peaks that occurred in different epidemics and pandemics in Canada. And when you think of that red line, that background level, you might also hear the term endemic used for that. And those shows look like single peaks, but what you'll see in some pandemics is what we call pandemic waves, where it's not necessarily all one peak, but there might be a peak, and then there might be a bigger one, and then a bigger one after that. So it's not just a straight, smooth line up and down. And the top one is death in the 1918 to 1919 pandemic, and then the bottom one is the 2009 H1N1, just looking at positive tests reported to the CDC, and it really showed that looks like there were two waves that we experienced. So then you come to what is pandemic influenza. And I struggle a bit with this because I don't particularly like some of the definitions that are out there on the web. And I found this article, which I thought was really good, that talked about the difference between a description of a pandemic, influenza, and a definition of one. And if you look at what we just talked about, influenza pandemic, you could say, boy, a lot of the seasonal influenza, you could really call it pandemic, but that's not the way we think about it. And this article discussed we kind of put a pandemic label and attached that severity component to it, really for planning purposes, because there are differences between preparing for seasonal influenza and that is widespread and maybe across an entire hemisphere, and between what we think of as pandemic influenza. And what we need to have a pandemic is a virus that's going to infect people, and that people don't have a good immune response to it. They haven't been exposed to that particular virus strain before. And then it'll cause disease in people, and then once it's in people, you get efficient human-to-human transmission. So you've all heard about people getting influenza from chickens in China, and it tends to be very limited and staying within the household and hasn't really acquired that ability to spread from human to human to human. But that's one thing that we monitor, because that is what would be very concerning. So all those cases and clusters are investigated closely to make sure that isn't spreading beyond the person who had the chicken in their home, or who was kissing their chicken, or slaughtering their chicken. And then just a little bit of background on how these novel influenza viruses arise. So I won't go into the whole structure. I'm sure you've had that multiple times in your micro classes and all your other influenza education. But we've got two surface glycoproteins that determine influenza A subtypes: the hemagglutinin, which is HA, or H, or the neuraminidase, or NA. And we now have 18 H's and 11 N's. The number keeps going up as people do more investigation and exploration. And we recently found some in bats in South America, so that added to the list. So we get novel when there's some changes, that when those surface proteins change, they can change in two ways, in a minor way or a major way. And when they change in a minor way, we call it antigenic drift. So they're tiny little changes, but the subtype doesn't change. And this kind of happens continuously because that virus is always trying to, avoid the antibodies and continue to replicate itself. And this is why seasonal influenza vaccines need to be changed every so often, and you monitor what's happening in the southern hemisphere so we can make a good, try to make a good match for vaccine in the northern hemisphere. So when there's a major change, that produces a new subtype, and it's typically caused by a genetic reassortment, where you have two subtypes are infecting a host at the same time. And this is one reason why we want to make sure people are vaccinated against seasonal influenza so that they don't have seasonal influenza in them and then get influenza from something else, like a pig at a pig fair. Or you can get a direct transmission, so you have a subtype in birds or some other animals, although we're not seeing that, and then that virus adapts to humans. So this is an example of something that people are very concerned about, is reassortment, where the avian virus and human virus both get into a pig, which is more likely to happen when they're living in close proximity, which is why you see some of these new things coming out of Asia, where the type of agriculture has close associations with the animals and the humans, but it could happen here as well. And then those two viruses swap genetic components and you get a new reassorted virus. And this is a lovely slide from the New England Journal of Medicine that shows what happened with different influenza pandemics. So the first panel on the left was the 1918 Spanish flu. We don't like to really call those things by a particular name because it winds up being all over, but that's what people have called it. And that was really that bird to human, and then in 1957, it was a mixture of an avian and human virus. In the 1968 epidemic, they had a mixture, again, of avian and human, and that could be the most likely, but we can't rule out other things in the future.
Hold on, I might have messed you up there.
Okay. Okay.
Out of the way.
I love this slide because I like to know what's in which species. The table on the left shows all the different H subtypes, so they've gone up to 18, and you can see 17 and 18 are on the bats. And then on the right is all the N subtypes and what they are found in. So you can see they're pretty much all found in avian species except the ones that are found in bats. And the other animals are cats, and for example, cats and dogs and horses. And they don't really think that canine influenza is transmitted to people or equine influenza, although there's always potential. And there's been very low risk from influenza in cats. But when we see those things happening, we're always watching, especially if it's in a household or in a shelter or a congregate setting. We like to see, public health is going to go and make sure that something hasn't changed in that setting. So veterinary public health helps with that. So one of the questions that came through to me was, who is doing influenza surveillance? So it kind of started at the big level, the World Health Organization. And they have a really good website. This slide, you can't see everything on it because they have multiple ways that they do influenza surveillance output. But I would go to that web link and take a look at those. And they're very good about putting out that information on a weekly basis. And there are a couple things I'm just going to dive in a little closer for you to look at in a bit. And then, actually I should put this slide earlier. The CDC has developed an influenza risk assessment tool, which is basically basically a method where a bunch of subject matter experts get together and they look at a new virus, and you have laboratorians, you have clinicians, you have epidemiologists, and they give their best judgment of a score of like low, moderate, or high risk for each of these sort of 10 criteria, and then they add them all up and they give a total to try and see if you have a virus in one of those animals and it comes up, what's the likelihood that that's going to be high risk for people. So they look at both the properties of the virus, the attributes of the human population, and then the general ecology and epidemiology. So they'll look at what's the variation in the genome of that virus, how good is it at binding to receptors. They'll look at laboratory studies and transmission in lab animals, and then they'll see is this virus susceptible or resistant to antivirals. And then they'll see in the population, has the population ever been exposed to this before? Do we have antibodies to it? If there's been some human cases, has it been severe in those cases? That's why they look at all of those avian influenza cases in people to see how severe it is. And then how close is it to vaccine candidates that have already been developed? And then they'll see, is it widespread in animals? If it's widespread in chickens in Asia, there's a greater chance for people to be exposed. So the more potential for exposure, the more chance it is for getting it into people. How well it infects other species, and again, what's happening in human infection. We'll go back to World Health Organization and then zoom in. This is that first map. Well, they'll look at globally, what's happening globally. And I really like this because we are not separated. It's a small planet. And as you know, people travel. You know, that's how we're bringing measles into the United States now, is people travel to other places in the world. So sometimes people think, oh, well, we're not going to test for flu because it's not flu season here. And they might forget to ask, maybe that person just was traveling someplace else in the world where their seasonal influenza is circulating, and maybe we should test for it. So I like to keep the global picture, and especially I know some of your facilities have travel clinics, or you might refer people to travel clinics, and so it's just a good idea to know what's happening. And then the World Health Organization will really, they're getting contributions from many, many laboratories in many countries around the world, and they will look at how many specimens were submitted and were positive for influenza by different subtypes, and they will post that so you can see what kind of subtypes are circulating. So for the lab people who are really into that stuff. And then there's other really cool charts that you can look at. So then I put U.S. CDC because CDC doesn't operate in a vacuum. All of us, your labs are part of our influenza surveillance. You send some samples of specimens to our lab, and our lab sends it on to CDC as well, and that happens across all other states. So they test a lot of patient specimens, and those go to public health. A smaller subset goes to public health labs. Then we send a subset of those on to CDC, and then they look at those. And they're saying they're looking at about 7,000 of those a year, and they'll look and see what's happening with antiviral resistance and susceptibility. They monitor that. And then they also pick candidates for vaccine production as well. And you can see what else they do besides the virologic surveillance by going to FluView, and there's a FluView Interactive as well. So this gets updated every week and throughout the influenza season. And they include outpatient illness surveillance. This is primarily with ILI-NET, which is outpatient reporting in Idaho, we usually have anywhere like 10 to 20, it varies, clinics that will report to us the percent of visits that were where people had flu-like symptoms. And we monitor that, and I'll show you ours. Then they look at influenza-associated hospitalizations. They have some core facilities that report that. Then pneumonia and influenza mortality surveillance, that's gathered from all the vital records departments across the country. And then they have a specific interest in influenza-associated pediatric mortality. And they've made that nationally notifiable, which allows it to be reported to CDC through like the communicable disease reporting systems, but it is reported through their vital records system, so it's a bit of a dual system, but there's been some concerns about that, and that's one of the things that we keep a close eye on to see what if a virus might be changing and see something new. So this is what we do in Idaho. That's the easy way to find it is just go to www.flu.idaho.gov. And we now, from there, if you see there's a link, I just took a little snapshot of it at the bottom there that says Current Weekly Idaho Update. You click on that link, and it will take you to this page, which is on Get Healthy Idaho, but it has a huge long string, and then I don't know if the little numbers at the end of that change every week or not, so I didn't want to put that in the presentation. But we'll do something very similar where we'll talk about the outpatient visits for ILI. In Idaho, we have over 60% of the hospitals, and it's about 88% of visits to emergency departments are captured in our syndromic surveillance system, and we have an ILI or influenza-like illness query in that system, so we report that. We have death reporting and also the virologic surveillance, and then Randy Pedersen is our influenza surveillance coordinator, and she worked using some CDC algorithms to kind of develop a better influenza activity estimate for our public health districts to give you an idea of what's happening around the state, because it's not the same. It'll really be different from the north to the south or to the east. And then one other question I had was, and I kind of think this relates back to measles, that's why it came through, but we know who's looking, but who's telling us and how? So obviously the World Health Organization will let CDC know what they're finding, and there's a variety of ways they're doing that. They're kind of hidden behind there, but I showed you some of them with like their websites, and they have direct communications as well. So CDC will communicate with three different groups, the Council of State and Territorial Epidemiologists, so that'll have our state epidemiologist, Dr. Christine Hahn, our deputy state epidemiologist, Dr. Catherine Turner, on that, and maybe other EPIs as desired or needed. They'll communicate with our state influenza coordinators and with our state public health preparedness directors as well. So we're all those are all within our Idaho Division of Public Health, and then there's two ways that we communicate that information back out. So the first is we will communicate mostly with the state level agencies, and we have an infectious disease physician list that we communicate, because our state epidemiologist, Dr. Hahn, is also a physician who's an infectious disease specialist, so she has a community that she communicates with on that. And then we'll also communicate directly to our Vaccines for Children providers through a constant contacts, basically email list that we have. And then we communicate with the local public health districts. And the first is mostly by email. The second can email or by call. If we need to talk to them about something urgent, we'll get on the phone and get them all together and talk about it. And then the local public health districts are the ones that are going to communicate to the healthcare providers in the district and directly to infection preventionists and to administrators in your facilities. So the facilities are in their jurisdiction, so they prefer to be the ones to have the immediate contact and coordination with them. So we respect that, but we will communicate to get the higher association level. So that's how communication goes. So they'll do that by email typically or by health alert. So if you're interested, you can ask for some of these things to be pushed to you. So the World Health Organization bulletin, you can sign up for that. You can subscribe to page updates. You can subscribe at CDC to get weekly flu seasonal updates emailed to you. And I really recommend, if you're not on the Idaho Health Alert Network, to be sure that you sign up for that, because that's how the Public Health District will push out more urgent messages. How many of you are in the Sign Up in Idaho on? Most of you. That's great.
Can I ask you a question about the hot alerts? Is there a way, because currently you have to go up and sign up for Public Health District, is there a way to get hot alerts like the whole for all of Idaho, or do you have to individually sign up for each district? Okay.
Yep. So we don't send out, as I was talking about, we don't send out health alerts directly down. What we do is we'll send a template of a suggested health alert to the district, and the district will decide if they want to modify that, if they just want to put their information on it, if they even want to send it out or not. It's their jurisdiction. So we don't send out any really statewide health alerts.
Okay.
So then I was asked about pandemic intervals, and this is a kind of a new framework that CDC has put together that deviates a little bit from the World Health Organization. So right now we're in that pre-pandemic interval, and then the pandemic interval, the crimson contagion, we were in the acceleration phase, and cases were increasing rapidly around the country. So really, here's where we're investigating those initial cases and learning what we can about that, and where we should be all doing our planning. And then here, again, this has that smooth curve. It's not going to be smooth like that in real life. And I really like this. It's a pandemic severity assessment framework, and there's a bunch of images, and I like this one from this article because it really puts things into context. People always want to know, well, how does this compare to this season, or how does it compare to the 1918 one? And if you have like how transmissible it is on the left and on the bottom, how severe it is, and the colors are really representing deaths. That kind of helps place things and get that context, like a quick assessment, and much more intuitive than just looking at numbers. So what are some of the problems we might have? Too many patients, and some of them might be sick and some of them might not be sick. And some planning needs might be call centers or nurse triage lines to help keep those worried well out of your office. Some places have thought, well, let's do a web-based self-assessment. This was done with rabies exposure in Utah, where they had a lot of people who might have been exposed to the human case of rabies, and they wound up doing the online self-assessment form, and that was mostly successful. And then crisis of standards of care, which I'll talk more about later. And then you might not have enough people to take care of those who are coming in, and not just because they're sick, but they might have to stay home because their family are sick, and also because CDC is probably going to be recommending that schools be closed anywhere from 2 weeks to 6 months. Yes. So there's a lot of pushback about that, and I might talk a little bit about that later. But in order to plan for that, you have to have a continuity of operations plan.
Parents trying to plan around that?
I couldn't hear the question.
For those on the phone, if you have a question, speak up. If not, if you could just mute your phone.
Oh, I think she said, could you imagine parents trying to plan for that?
Yeah.
Well, we struggle with this, and so does the National Federal Department of Education. I think there does need to be more discussion on it, but that's a personal opinion. And then we might not have any vaccines, so you need to do non-pharmaceutical interventions, which we call NPI. You might have vaccine available, but there's not enough for everybody, so how are you going to decide to give it to? You might not have enough antivirals. Again, the crisis standards of care, same thing with insufficient ventilators and insufficient N95 respirators. We'll talk about NPI. So how many of you have heard of crisis standards of care? 1? 2? Great. I stole these slides from Dr. Marsha Whitty. I tweaked them a little bit. But crisis standards of care is really important, and we know this is a gap, and that came out again in during Crimson Contagion, is that Idaho does not have a crisis standards of care. And this came about from our last pandemic, and ASPR said, we need a committee to develop guidance on that state and local public health and health sector agencies can use to figure out what kind of standards there should be when we have a catastrophic disaster and things are in short supply. It might be your community's infrastructure is gone. You think of earthquake or fire. You might not have enough officials to help out. In pandemic influenza, but they might be 40% of the people might be absent. You might have community functions that are disrupted. And you might not be able to get aid from your surrounding community because they're affected as well. So what do we do? So this crisis standards of care is a change where you can't operate the way at the level that you would normally operate because of a pervasive problem like pandemic influenza or some other disaster. And this is supposed to be declared by the governor, and that these crisis operations will be in effect for a sustained period. But right now, we don't have any statewide guidance. And they're a little bit different because the care is looking at what you have to do to just emphasize the needs of the community and not just an individual patient. And you need to allocate resources to who's going to benefit the most. If any of you have worked in military or a big disaster situation, you're starting to tag people who you think are going to make it and or not. That's going to happen in these situations. And crisis standards of care can really help you so you're not the one who's forced to make a decision. You have some guidelines and structure and support around that. And just some examples like who gets to go into the ICU, who gets a ventilator, who is EMS going to go to and who are they going to wait on, and who's going to get those antivirals and who's not. So if you look at this, there's kind of a continuum of care, and I won't go into all the details, but we have the conventional care, which is what you do normally. Contingency it's not consistent with what you do normally, but it's kind of functionally the same. Maybe you wouldn't normally put so many beds in the hallway, but you can do that and provide the same care. And then crisis is where it's not consistent with your care. You're doing the best you can, but you just can't do it all for all those reasons we already talked about. And this is more of a graphical view of looking at conventional contingency and crisis care, and when you might think about there's a potential you might want to start looking at crisis standards, and when there's really a trigger for a crisis standards of care. And there's 5 elements. There's ethical, there's legal authority, there's engaging the community to make sure you have buy-in from everybody, and communities are different. If there may be guidance from CDC saying we're not going to give vaccine and antivirals to the elderly, but the Native American community might say, nope, we value that we're going to give it to our elders and you're not going to tell us what to do. So it can really vary by community. There's indications and triggers, again, so you're not having to make a decision, and then it's evidence-based as much as possible. I won't go into this graphic in detail, but it kind of shows the whole process and the building blocks and the pillars of developing a crisis standards of care guidance document. And these will all be posted so you can look at them in closer. So the ethical elements are, you want to be fair, you have a duty to provide care, but also be a good steward of your resources. You want to be upfront with what you're doing and let people know. You're not hiding, how you're making those decisions. And you want to make the decisions consistently so they're applied across the same people. And they're really looking at proportionality, dividing up the resources into a population base, for example, and then accountability for what we do. And the legal elements are things like emergency declaration, legal rules that will allow you to change your standards of care, what in your scope of practice, looking at what's your liability if you do that, and what kind of mutual aid agreements you can have to try and bring in those other potential resources. And we need to really understand all of those to have a good crisis standards of care document. And these are all the stakeholder groups. So, of course, we have the government, we have EMS, and we have all of you, including home health, are all stakeholders in this, and the community as well. So that's all I really want to say about crisis standards of care. We don't have them, we need them, and I'll have some examples later. But Dr. Whitty said if you're interested in participating, they want to develop a large working group, so it might be that you'll be represented by somebody on that group. It hasn't all been decided yet, but regardless, if you're interested, just email her and let her know. So talk about non-pharmaceutical, those NPIs, or non-pharmaceutical interventions. So these are some options from NIOSH. This is a really good link to go to. And they look at engineering administrative controls and PPE, which will focus on respiratory. Of course, engineering, these are things you're familiar with by the work you do every day, so I don't need to go into details, but things like glass and plastic barriers to the public, direction of airflow, ultraviolet germicidal irradiation, patient isolation rooms. Many of you bought some of these expedient patient isolation rooms where you can set them up quickly as needed. I saw some cool demos way back when. I hope they're still working. And then they had ventilated headboard, which was new to me, and you clicked on the link and it didn't go anywhere. So I wondered if any of you, I thought that probably means the guidance is going to change. So I wondered if any of you were aware of the guidance around ventilated headboards, or knew if it was changing, or are using any in your facilities. I haven't heard that yet. No. Well, if those links become live again, I will update this before we post it. And then administrative controls, many of these are the same things that you're probably already using for seasonal influenza. Cohorting is not just putting people, like patients with all who have influenza together, but also keeping the people who are taking care of them the same. So instead of rotating somebody what they're taking care of the influenza patients and then they're going someplace else and somebody new comes in, it's really cohorting the caretaker with the patient at the same time. And then we'll talk a little bit more about the last three, social distancing, visitor policies, and training. So social distancing, I won't talk about the seasonal influenza things because you do that, but some things that might happen in pandemic that are a little bit different, they want to make sure that you're not close up with the patients or with each other. So you might say, we're going to cancel meetings that we don't really need. Everybody wants to shake hands, but maybe we should do, some other things. They might close venues where people gather, like maybe there won't be everybody coming into the cafeteria, and they might say we should close the child care, which is another issue we can imagine. They might change the way the office is laid out spread things out more so you're not sitting so close to people. Do more things remotely that you can. One of the physicians I know was just so excited when they moved from paper-based to electronic records, because then he could go home and eat dinner with his wife and then get on the system and update all his charts instead of staying at work. So those electronic health record systems that we love and we hate, they're really valuable for in situations like pandemic influenza. And then give priority, so people who are at high medical risk for influenza, pregnant women or people who have other conditions, if you have choice, those are the people you need to take care of first. It's a little bit different if you're going to have visitors, and there's reasons for visitors for mental health and other purposes, but they should be given PPE, and you should show them how to do it and make sure they do it right. And you might have, in these situations, you might have the patient's family actually doing patient care. There are things that they might be able to do if you give them training on PPE and hand hygiene. And then because they're doing that and because they've been in close contact with someone with influenza, then you want to keep an eye out on them because they're more likely to get it, and so can kind of screen them in particular if they're going to be coming into the facility. So now I want to get into PPE, but really I'm just going to talk about respiratory protection because we're pretty sure there's going to be N95 respirator shortages, not only because everybody wants them, but because there's going to be less production in the facilities because people are going to be sick. And there's some relatively new guidance by NIOSH on extended use and limited reuse of N95 respirators in healthcare settings. And this came out after the 2009 H1N1 where people were saying, what are we going to do? We don't have enough masks. And the masks you sent us, we don't use, and they're not fit tested for, and we don't like them anyway. So federal government did work on that problem, and this is what they came up with. And extended use is preferred over reuse. And extended use just means you keep it on for a long time. You're not taking it off and getting a new one, or taking it off and putting it back on and taking it off and putting it back on. You just keep it on. And mostly for both of them, if you have use them for aerosol generating procedures, you want to discard them, or if they get contaminated, discard them. Or if you have close contact with somebody, there's some ways to preserve them by using a face shield or even putting a surgical mask on over the N95 respirator. And then if you touch them, you can wash your hands. And that would apply really to both of them. So respirator reuse the same. You can also use a cleanable face shield. If you're going to reuse them, you want to store them so they're separate from each other, and you know whose mask that is. That's, of course, really important. And then donning and doffing, you're probably well familiar with that from some of the training that you've already had with Ebola. So there's some risks. Contact transmission from touching a contaminated respirator. And there was one study, and they found that nurses averaged 25 touches per shift to their face or to their eyes or their respirator. And there's also, with multiple donnings of a respirator, that fit gets worse. So this article talked about the impact of doing that, and they looked at 6 certified respirators. They had 10 people who were experienced at wearing respirators, and they fit tested them they tested for fit after 20 donnings. And that top shows the percentage of passing fit grade. So it's not too bad after 1 to 5 donnings, but after 16 to 20, it went down to only as low as just about half of them had a proper fit. And some models were better than others. And at that time, they felt that maybe 5 donnings could be performed. But it'll vary again by the circumstances of what you're using. So what it just came out in 2019 is these reusable elastomeric respirators in healthcare, considerations for routine and surge use. Has anybody seen this document? Is anybody using these elastomeric respirators? They're kind of rubbery. I found that they irritate my skin a little bit, and other people have that.
Is it made out of rubber, or?
It's made out of an elastomer, which is
plastic.
It's a rubbery, light plastic compound. So yeah, some people are sensitive to that, but that can happen with anything. Yeah. So
Not latex-based.
Pardon?
But it's not a latex-based,
Not
rubbery plastic.
No,
Okay.
it's a rubbery feel plastic.
Like
It's not latex. Yeah. But sometimes people get rashes, or they'll just break out, from having that. But not everybody, and it varies. Like some models, it might be just one model. But they found that they're efficacious in a controlled setting, in a laboratory setting. The study found they're viable for both routine and surge use, but there were gaps and challenges in how to implement them, like properly cleaning them and training, you can imagine. But I think it's something that's definitely worth looking at. It's the latest in respiratory care. So next I want to talk briefly about vaccine. Some relatively new guidance came out from CDC in about 2017 on how we're going to allocate and target pandemic influenza vaccine. Because you all heard there's not going to be enough. It's going to take 6 months to get any, and when it comes out, there's not going to be enough. So who are we going to give it to first? And inside this document is a chart on the right that shows different categories and population groups, and then what tier they're in, depending on how severe the pandemic is. And I really encourage you to take a look at this because healthcare providers are in Tier 1, but if there's not enough for Tier 1, you're going to have to ratchet it down. And these are some suggestions for when vaccine is in extremely short supply are frontline, inpatient, and hospital-based healthcare personnel caring for the sickest people and people with the highest risk of exposure, frontline outpatient healthcare personnel, and remaining groups such as the healthcare personnel who were not previously vaccinated. And OSHA put out this document that has the pandemic influenza exposure risks, and you can look at it and use this as a tool to help assess if you're going to limit it, you don't have enough to vaccinate everybody in your facility, who's going to be at highest exposure risk, and this can help you figure that out. So can you identify it right now? Would you know who's frontline and who has the highest exposure risk? Would you know who's been vaccinated? Do you have an idea of how you would track that? Do you know who's most vulnerable? Like if you were going to vaccinate, I know this nurse is pregnant, or I know this laboratory technician has cardiac disease. Would you know that, or how would you get that? Things to think about. Talked a little bit about community mitigation and the school closures and mask gathering cancellations. This is another 2017 document. I'm not sure how acceptable these will be in Idaho. CDC did some outreach and had focus groups and some surveys where people said, we wouldn't have any problem staying home, but I really wonder who was available to participate in those focus groups. And then, I know we're getting close on time, but we good?
Yeah, here.
I'm going to pass over.
You can go for another 15 minutes.
Oh, really? Oh, okay. But this will be quick because it's really meant to be a resource for you to find resources, and I actually thought of a couple to add, and you might have some that you said, that was on there, and I think it'd be really valuable to add, and I can just add it before we post it, because this has to go through an approval process before I can do that anyway. So, ask for Tracy Pan Flu. I really recommend this. They have, it's a great resource where they put everything there, not just for pandemic influenza, but for all other kinds of disasters. It's a really good resource. So there's a link there for hospitals, and there's a link there for other kinds of healthcare facilities. And these will get posted, so you don't have to worry about trying to write down all that huge long link. If you just Google Ask for Tracy, it'll come up. And Crisis Standards of Care is an Ask for Tracy collection. So this shows you the header for Ask for Tracy's site, and then they have these topic collections where they pull together everything on one particular topic. And for example, this is a document for hospital facilities for implementing crisis standards of care plans. And this is another one about functions for outpatient care facilities for crisis standards of care. And now CDC has put together a crisis standards of care for pandemic influenza with some triage tools. And there's 3 different tools, but the one I'll show is a pandemic influenza triage algorithm. People like algorithms. I love algorithms. I love flowcharts. It makes it easy. You can just go yes, no, and follow it down what you need to do. And when you're really busy and you're in a crisis, it helps to have those. And then there's some community site tools on the other tabs there. And then I was at a meeting, and actually I think it was the earlier CDC pandemic influenza exercise in the fall before we had Crimson Contagion. And a representative from Utah was there, and she's kind enough to send me the guides that they had developed in Utah. And it's always nice to take a look at what a neighboring state has done. And this is really helpful. For example, it has in here, how would you triage a ventilators? It's got a very simple thing. I was kind of hoping the Crimson Contagion would drive that. We're probably going to run out of ventilators, and do we have a decision-making tool for figuring that out? But we didn't quite have enough sick people, I think. And then there's planning checklists for long-term care facilities on the CDC website. Have anybody seen these?
I have them available if I need them.
What's that?
I have them available if I need them.
Yeah. And I've liked this for long-term care providers. California put it together. It's 150 pages long, but I just copied the table of contents there so that you can see all the kinds of things that were covered in their workbook. So I think this would be really helpful, maybe more helpful than a checklist to see what's been put together by another state. That's the hospital pandemic planning checklist. And then this is the continuity of operations template for pandemic influenza that FEMA put together. Has anybody seen these? Do you know if do you have continuity of operations plans? We just are working on having ours updated because the original one was in response to an explosion in one building, and it didn't cover all hazards, and now we cover all hazards, including pandemic influenza. And there is a FEMA course that's specifically on continuity of operations for pandemic influenza. And there's some modeling tools. We sent out a survey of the infection preventionists, asking if they'd be interested in this, and we had quite a few people responding. If you haven't responded or you didn't get that survey, you could just email Susan Hepler or email me, and we can send you a link to that, asking if you're interested in training on any of these tools and what the best method for that was. And most people said yes, and by webinar. So there's a flu aid, which looks at impact in your area in terms of deaths, hospitalizations, and outpatient visits. And the top image is just kind of the landing page for the tool, and then the impact on the healthcare system is shown in the image on the right. And you put in information about the number of beds you have and how long people might stay, and then that will help you look at what the impact will be. And then there's flu surge. So you take some of that information from the first tool, and you can plug it into flu surge. And it looks at hospitalizations and the number of people who need ICU care, those who need ventilator support during a pandemic, and it looks at your existing hospital capacity, and it puts together some cool outputs. For example, the first one is admissions by week of the pandemic, and then it gives you a most likely minimum maximum scenario for hospital admissions by week of the pandemic. And then another output will give you admissions by day. And then the bottom one will plot out for you your hospital admissions and look at your capacity and what percentage of your capacity is needed to take care of that, which you can all do manually. It's nice there's a tool already available with all the calculations done inside. Same thing with ICU and ventilators. And that's what I have. So I had a couple questions for you. Once if there are resources, does anybody know of a really good resource that I didn't show up here that they'd like to share with the group?
CDC's usually my go-to for it.
Mm-hmm. And there's a lot from CDC, but there's some from different places as well. Okay. And then I mentioned, I was talking to Debbie earlier, and I will put on a couple sites that have continuing education for non-pharmaceutical interventions and a few of the things we've talked about. So I'll add those to the resources so that you can go in and get some CE credits. Great. And then
any questions for Dr. Carter?
I have a question. So when we're talking about the crisis standards of care, you showed that kind of tiered approach, like federal, state, et cetera. From a federal level, do we have a crisis standards of care that the states could kind of pull off of? Does that exist?
It's a guidance document, it's a very large one, on how to go about developing your crisis standards of care.
Okay. So there isn't one from a federal level necessarily.
So that you could just, we're going to adopt that. Because they need all that engagement.
But other states have developed, other states have, and you can pull from them. Do they push that out?
Yep, Dr. Whitty has some links to crisis standards of care that other states, and if you Google them, they'll come up. And they usually post them. Like Utah is an example, and then there's some further back east.
Yeah.
There are places where they're usually they're bigger and have more resources and more people to help with putting those together. And Dr. Whitty's got I won't say she's the lead, but she's the initiator, and then she'll move it, and it'll be moved forward through our preparedness program.
That's what I was thinking. That isn't a lot of that with the emergency preparedness, and that sometimes is a little separate than the infection prevention side because it's a bigger umbrella, kind of.
Right.
Because that's what I was thinking, is that in our facility, we have a different one that's an emergency preparedness coordinator, that's not me. And
Right.
so I was thinking a lot of that you're talking about might be under that, and so maybe that's why I wasn't so familiar with it.
Yeah. And then we have a lot of places where the infection preventionist wears 10 different hats.
Right.
And that's one of them, and emergency preparedness is one of them, and then
Yeah.
influenza coordinator is another one. Yeah.
Well, thank you. I really appreciate your time. If there's any more questions, did you have a question?
Yeah, I have another question, but I'll let Trina.
Okay.
Just as a resource, and I haven't played around with it too much, but it's called nextstrain.org.
Mm-hmm.
And they do kind of real-time, what they say is real-time tracking of pathogen evolution, and they have some pretty neat, you can explore like seasonal influenza or avian influenza, and it's out of someone from Fred Hutch. So they kind of run that.
Thanks.
So that's a good resource to maybe take a look at.
I think that's one of the frustrating things is when you're in it and you're trying to find out how much there is and where it is, and it's everything you go to look at is like last year's data. It's really hard, I think, when you're like wanting to know now data. And
yeah, and it's hard to get immediate, but you'll get usually weekly.
Yeah.
But there's always going to be a lag, because if you think somebody's sick and then they come in and get sampled and then, that's rapid test positive, and then it goes to our lab, and then it goes from our lab to CDC, and there's going to be, even though it's every week, it's reflective of what's happened probably 2 weeks before that, and a little longer globally. Yes.
From the exercise, the Crimson Contagion that Idaho participated in, was there anything that really stood out to you, any like lessons learned, or anything we need to be working on? Be better at?
Standards of care! So I didn't have a lot of visibility with what was happening with the hospitals, because most of the hospitals were playing more with the public health district. And although I did some controlling and evaluation, I was a lot in another room in a sim cell, so I didn't see really what was happening. I know we put out a hospitalized case information survey tool that some of you helped pilot a while back, and we had 2 out of 3 responses to that. 1, I think, worked well. 1 uploaded a file that we had some firewall issues with downloading, and so we had to work out. That was a good test. So we had some technical issues, but I think that will work for us. Obviously, that's only going to be done usually early on to assess what's happening, and then after a little while to see if anything has changed. So it's not something like, we're going to do this, constantly, because you guys are all going to be trying to take care of things going on in your hospital. Might be CDC, I think, in 2009, H1N1 wanted that weekly as well. I think they're realizing that there's not the great benefit to collecting that detailed level of data weekly. So there were a few technical challenges with that. I don't think we got to the point where we were testing a call for ventilators from other places, and I think we were kind of hoping that would happen and it would result in an SNS request, but we didn't get there with the scenario.
Okay.
How about you? For any of you who are playing, did you have some observations from your experience?
Well, I think our file was the one that had issues with the firewall on, so I know that. I think it just really stimulated a lot of good conversations about establishing policies. A lot of what you went over for the non-pharmaceutical interventions, like looking at work restrictions, who are we going to give vaccines to versus who aren't we, and just kind of outlining that a little bit more. We have kind of a general policy over that, but it doesn't go quite to that detail. So just knowing what our resources are, maybe trying to plug that into our policy. And then talking about cohorting patients and where can we do that. Just looking at our HVAC systems, do we have like 1 or 2 units that we can just designate for as an influenza ward. So that was helpful with our building services folks to see what our possibilities are. For me, that was really helpful.
Okay. And so we didn't get into alternate care sites, and you think about that in earthquakes or floods, but oftentimes you don't think about that in pandemic influenza, but you might need to be putting people in alternative care sites, which the first thing people think of is long-term care facilities. And then what people can be taken care of at home and can be taken care of by people at home or home health and don't need to necessarily be in a hospital situation, or they might be in a hospital situation, but they're just not sick enough compared to everybody else. That's where all the crisis standards of care come in.
Any other questions for Dr. Carter? Anyone on the phone have any questions? All right, well, thank you for coming. We really appreciate it.
I appreciate it. Okay, quick questions for you, just as, quick feedback. Did anybody have one new resource that they found out about today?
I didn't know about the NIOSH non-pharmaceutical inventions page, so that's definitely something I'm going to go look at.
Did everybody else, that was all something you'd already seen?
The respirators, I've never heard of the
New respirators, but
Okay.
Well, and that the CDC has long-term care specific stuff. For a long time, they didn't have anything that was long-term care specific. So.
Yeah, we're getting better with that. And how about, did anybody after this, come away with just one action item for what you might do now that you weren't planning on doing?
Well, I'm planning to do it this weekend to look and get familiar with all the resources that they provide, just to try myself to be, familiar with them. And then probably start to ask the question of the organization here, what we have and what we don't have.
Okay.
Be prepared for the flu season.
Right. And I knew I needed to do some policies on the pandemic stuff. I don't have a policy at all on that, and that's what I'm really excited to gather a few resources to help do that.
Okay.
I'll definitely use some of these resources to update our policy as well.
Well, thanks. You're really attentive and kind, and I appreciate that. It was fun. This was one of my topics of great interest, so but feel free to reach out to Susan, and she can tap me for things. And our preparedness program, as you might all know, we lost our healthcare preparedness program manager. She went to bigger and better things. So we have an opening. If anybody's tired of a clinical setting. So that's another place you can reach out to.
Awesome. Well, thank you so much. I appreciate your time.
Thank you.
Thank you for sharing your knowledge with us.
Are we going to do any roundtables?
Oh, we're a little over time. Is there any roundtable questions, any topics out there that people want to bring up or chat about?
Perhaps you would like to know what we did at our facility. We have a supply room, and there's like a walkway that goes through it to the bathroom. We're going to remodel, and that'll all change. But in the meantime, we go here for supplies, we go there for supplies, we go through here into the kitchen, and we need to sanitize before we go in to supply. So I hung signs from the ceiling, and Susan Hepler asked me for a copy of that, and I thought maybe she wanted to bring it here, but she's not here. So
She just may.
So I have that if anybody wants to see it. I made copies.
Okay.
But people at work say it's really helping them to remember.
Good.
what does it say? Just wash your hands before you entering, or?
It says stop. And down at the bottom it says hand sanitizer. I have it if you want to see it.
Oh, fun.
So it's not my copy that I hung at each entry point, is a brighter red. Really, fine capture red.
Yeah.
So.
Well, that is a
Very
good thing.
catchy, I can see it.
Yeah.
Anyone on the phone, any roundtable items?
This is Amy Bearlocker. The only thing I have is if anybody has any new members that are wanting to join APIC, let me know. I've got like a $20 off discount code until the end of September. So if anybody in your facilities is wanting to join or planning to join, reach out to me and I can get that to you.
All right, well, thanks everybody, and have a lovely weekend.